Now I would like to introduce you to our next panelist, Dr. Gene Lindsey. Dr. Gene Lindsey is a physician. He is currently the president and CEO of Atrius Health and Harvard Vanguard Medical Associates. Please help me welcome Dr. Gene Lindsey.
Tricia, I want to thank you for introducing me as a physician because it gives credibility to what I'm going to say. In fact, I'll try to enhance my own credentials. But before I do that, I want to tell you that this talk will be primarily extemporaneous because I had been told I got to talk for 10 minutes, and I discover to my delight that I get to talk for 20 minutes. I was sitting here, it occurred to me that, this is strange, I'll reveal something to you about myself. I listen to a lot of podcasts, and many of the podcasts I listen to are sermons. And they turn out to be about 20 minutes long. And so tonight you, on this very holy week, because two major religions have significant holidays this week, you're hearing 4 sermons. So if you can imagine 4 20-minute sermons, in essence, that's what you're probably hearing. And I think it's about a subject that's as close to my heart, almost, as some of the more spiritual things that I hold at a high degree of personal value. There's nothing in our common interactions with one another that's more important than how our society takes care of each of its members. And so if I, as sort of a disclaimer, if I say something that offends some of you because of your own political position, I apologize ahead of time. I will blatantly tell you now before I start that I feel strongly that healthcare, it should be an entitlement. I had a very difficult time personally when it turned out to be a mandate, which I felt was philosophically not quite what it ought to be, but the truth be known, sometimes half a loaf is better than the whole loaf. And I'd like to use one of Michael's slides. Actually, if you'll go back or look in your handout here to the 3 key issues in U.S. healthcare reform policy. Access, cost, and quality. Through most of the last 40 years, people in academic positions told us that you could pick any 2 of those 3, but you could not have all 3. So if you wanted to actually extend access to everyone, it was either going to cost too much money or you were going to give everyone low quality care. Or if you wanted quality care and access, that the cost would be extremely high. But the challenge that the Affordable Care Act and also Chapter 224 and a whole string of acts before that in this state give us is to actually come up with a way where we can have all 3. Because how many of you have ever heard the term triple aim? I ask this question a lot, and I'm surprised to understand just by my own polling that not many people who should know the term triple aim actually know it. So don't feel bad if you don't know it, because trust me, before the evening's over, you'll at least have my point of view about it. So how many of you know what the triple aim is? Good. I'll get to teach. This is like a teach-in. Maybe it's more like a teach-in from the 60s than a church service. But the triple aim was initially enunciated in 2007 by the Institute for Healthcare Improvement. The major author is ascribed to be a fellow named Tom Nolan, who's not a physician, he's a statistician. But it essentially says that our goal is to give quality health care to everyone and simultaneously improve the health of the community for and within sustainable costs. Now, the sustainable part is very difficult. In fact, the healthcare that we're now experiencing, further exacerbated by the worst scare tactics that people can imagine associated with the Affordable Care Act and Chapter 58, which is the name of the law that we passed here in Massachusetts in 2006, is that costs will accelerate. And they really can't go any higher, because right now we're spending close to 20 cents of every dollar on health care, which is terribly distorting the rest of our society. So when I went to high school and junior high school, public school, we had music lessons. We didn't have to pay to participate in the athletic events. We had a nice library. That's not true anymore. When I went to medical school, I didn't exit medical school with hundreds of thousands of dollars of bills. I actually exited with $10,000 of bills, which I didn't have to even begin to repay until 10 years after I had left medical school at 5 3/4% interest. So I ended up getting a little coupon book that had 120 coupons in it, each for $100.99. And I was already in practice for quite some time, and trust me, I spent more money than that taking my wife to dinner on weekends. So I essentially had a free medical education. Our society could provide that 40 years ago. Something's happened since then, and we can't. And I think it behooves us all to conceptualize how we can get back to where we were. I was asked earlier this year to give an oration at the Mass Medical Society, and in essence, what I talked about really began with a picture that I'm sure many people in the room can conjure up. How many of you know Norman Rockwell? How many of you probably don't know the name of the picture. Dr. Melman is the name of the picture, but you might be able in your mind's eye to remember the picture of the kindly old doctor sitting at a roll-top desk with a little girl standing in front of him, and he's listening to the girl's her doll's heart with his stethoscope. I see a lot of people nodding. Yes, that is the image of care that most of us as individuals sort of carry around in our heart of hearts. But what we get, pictured to us, particularly by people who want to make us upset, I love Atul Gawande. I know him personally, but he wrote an article this year in the New Yorker called Big Med, where he compared healthcare to a cheesecake factory. Many of you remember that, to the Cheesecake Factory restaurant system. That actually was a very, very good article, and what it entailed was some of the systems changes that we need to do. But what it didn't say is that if we can actually accomplish these tasks, take waste out of healthcare, we might have an opportunity to simultaneously have healthcare for everyone and have it feel like the care we got from Dr. Melman. So let me get into my slides here now. I'm sure that many of you don't know, I don't know how to operate. Okay, so what is Atrius Health? Atrius Health is a relatively new phenomena. It's a coming together of 7 organizations now. It began as a concept in 2002 and actually went into business in 2004. At that time there were 4 medical groups. It's been expanded now to 6, and I think most remarkably our most recent member of Atrius Health is a nursing organization, DNA Care Network and Hospice. One of the reasons that, the specific reason that we did that is that healthcare is not a physician-only activity. And 2, if we're going to begin to improve the health of people, we need to create new and innovative ways to deliver care. If you look at the people who are in the hospital right now, about half of them are there with things that in technical talk we call ambulatory sensitive diagnoses, basically chronic disease. And it should be considered a sentinel event if anyone with a chronic disease goes into the hospital. I mean, we should be managing them in the ambulatory environment so skillfully and so in such a focused fashion that it's the rare occasion for an individual to be admitted with a diagnosis of congestive heart failure, COPD, diabetes-related illnesses. And for those many who do get admitted, a little creativity should allow us to take care of them in their home where they're not subject to the same awful infections and other complications, particularly with the frail elderly, the disorienting realities of being out of an environment that they're comfortable with. I'll tell you a side story. My mother passed away this year at the age of 93, almost 94. She had been getting standard health care in the United States in a very fine system of care just north of Atlanta for several years. by last May, you know, my sister was taking her to approximately three office visits a week, and she'd been admitted to the hospital multiple times, several of which were for more than $100,000 admissions, like 2 weeks in the ICU. She said she'd had enough. It was actually really difficult for our family, particularly my father, to process the idea of, quote, giving up. At the time she gave up, she had a serum sodium of 108 and wasn't feeling all that well. Those of you who are nursing know that that doesn't make you feel all that well. And she was essentially a victim of her diuretics and you know, the care in the ambulatory environment that she was getting. So she gave up. Most of her medicines were stopped. She entered a home care program, hospice. My father was taught how to give her medications for comfort. She had someone come into the home 3 times a week and give her a bath. Pretty soon she was sitting up in a chair. Twice during the next 7 months she was admitted as an outpatient for hospice inpatient. The first time to give my dad some relief, he's 92, and so and the second time because she had begun to have seizures as a terminal aspect of her disease. The bill came to my dad last week for that 7 months of care, just a demonstration bill. It was $40,000. She never went back into the hospital. She never had another CT. She never had another MRI. She didn't take most of the medicines. She actually felt better and lived longer than anyone would have predicted had she actually continued with standard care. I don't know what standard care for a 93-year-old is. And trust me, I do know how to practice medicine. I meant to give you my credentials. Over almost 40 years, I've had more than 125,000 office visits and about as many visits to hospital patients in the hospital, and read 250,000 EKGs. So I guarantee you I know what the practice of healthcare is like. And what she was getting prior to going into hospice was pretty much standard fare. I, as a physician with almost 40 years of practice experience, did not really understand the power of that tool until I actually saw it in the life of my own family. So I believe that if we put our minds to it, we can actually come up with the solutions that actually feel better, more like old Dr. Melman, and actually deliver to ourselves a product that will be more comfortable for us, give us more relief, better life, and actually allow us to do it at a sustainable cost. And in fact, a great deal, as has been pointed out by John, of the finance of the Affordable Care Act is built on the hope that we can practice better. So let me sort of show you how we're trying to do it at Atrius. We're very proud that we were chosen as one of the 32 pioneer ACOs. Now, if you look at the bill, in one segment of Medicare, CMS is CMMI, which is the innovative wing of Medicare. And part of the Affordable Care Act set up the experiment of trying to see if you could create an ACO where patients had full choice. They can see anybody they want to see, but yet they have, there is one organization that is attributable for their care and actually accepts the responsibility. You say, that's crazy. You know, it's hard enough to manage a patient who has to see you because there's a contract that says they have to see you. And you're going to assume the losses of someone who can go anywhere they want to go? I heard Elliot Fisher speak earlier in the healthcare reform period coming up to the law, and he was the guy who actually invented the term ACO. And what he described was a concept that really captured my imagination. If in fact your organization can create a product that's so good only a fool would leave it, then you can actually imagine operating in an environment where you don't have a contractual obligation, the patient doesn't have a contractual obligation to stay with you. His term was, there's no fence that's better than a green pasture. And that really resonated with me, and I think it has a lot of substance to it. So in essence, we've been trying to create a green pasture for the frail elderly. Part of that, obviously, then was to bring in the wonderful skills of our nursing colleagues and help us focus their knowledge and abilities on attending not only this population, but other people for whom care can be enhanced in the home. And we're working on further innovations with them to move forward with the idea of taking a lot more care out of the hospital appropriately. I didn't know when I was in medical school that Dr. Ebert, who was the dean then, was actually involved in a conspiracy to create socially responsible physicians. But anyway, about the time I started medical school, he gave a speech at Simmons College where he said something that I think really resonates today. And actually, there's the framework of the triple aim in this statement. The existing deficiencies in healthcare cannot be corrected by simply supplying more personnel, more facilities, and more money. That statement is as true today as it was then. These problems can only be solved by organizing the personnel, facilities, and financing into a conceptual framework and operating system that will provide optimally for the health needs of the population. You can take that statement and think about it for a long time, but if you do and sort of begin to think about some of the more positive aspects of the Affordable Care Act, it's actually a pretty creative exercise. And it really opens your mind to what we could do if we put self-interest behind us and stop worrying about how much we got paid and start worrying more about the job that we had to do with one another, for one another. So, I would add, since I have 20 minutes, how much time do I have left? Oh, I'm getting close to the end. All right, that back in 2006, before I became CEO of the organization, I was chairman of the board, and Chapter 58 was being passed. It was clear then that the moment we're having now would come. Our organization had been very successful in getting high-cost contracts that allowed us to operate in a pretty sloppy management way in some of the biggest and most expensive healthcare organizations in the world. And what has happened since then, predictably, since 40 cents out of every tax dollar in this state goes to healthcare, since there's a $20 billion unfunded retiree benefit issue in healthcare for the cities and towns of Massachusetts, there's a real crunch on not adding any more dollars to healthcare. So what we've seen in our organization over the last 5 years is that our 10% year-over-year increases in reimbursement have now gone to -1 or so. So we got paid less to do more in 2012 than we got paid in 2011. But actually, it probably will go even lower than that. So if you were looking at this prospectively 2006, you realize and could realize that that was coming, then you would have begun to do the work that we've been trying to do. The trouble is that it takes a long time for people to catch on, and I think we're not completely prepared for the slide that we have ahead of us, but I think we're better prepared than most other organizations. So what I should point out, you can read this, healthcare in Massachusetts is in receivership. I don't know if the phrase receivership means anything to you, but our taxpayers and employers have been trying to have a conversation with the medical community through the legislature for the last 6 years. And with each bill, we keep pushing back and saying, we don't get it. Why should we do that? You don't understand. It will be hard for us to accommodate to what you're asking for. So we've now gotten to the place where Chapter 224 is a list of onerous responsibilities that organizations like mine will have to respond to and are now saying we can't. I think the truth is some of them don't make sense, but they make sense in the context of the fact that they've now gotten our attention and we are engaged in trying to do a better job. I truly believe that. I think we're finally responding, and maybe we have hit the nadir of self-interest and we're now going to recognize that the only way out of the woods for all of us is to work together. So I think Chapter 224 is actually a very positive piece of legislation, and it challenges all of us, I think, to find new and better ways to work together. It really moves transparency up to the top of the list, and I think when things become transparent, there's no place to hide and you get the work done. right quickly to finish up. I'm technically challenged here. Find the right button to, well, there it says next, right, okay. So if you look at, when you have a chance to study this, if you look at the algorithm of how we've tried to approach the Affordable Care Act, I think you will see that there's been some thought put to it. Finally, I'd like to talk just for the last 30 seconds. So what we're talking about is a process of adaptive change. Adaptive change is the kind of change we all go through that we don't like. Technical change is like you bought a new iPhone. You know, that's fun. You play with it, you get to be an expert pretty quickly. Adaptive change is where everything that you ever knew before doesn't work anymore, and you've got to figure it out, plus it hurts to do it. And so we are all going through a process of adaptive change. But it's helpful to understand that we're doing it together. And if we have a positive attitude and keep our eye on the objective, which is better health for individuals, better health for the community, and a sustainable cost, then in fact I think we have a chance. So we do it in our organization through groups, a lot of stickies, felt tip pens, and group activities, and that's where I'll leave you.
Thank you so much, Gene.